On the Gary Bisbee Show, here are practical lessons from today's healthcare insiders. We'll uncover stories about their challenges, paths to success, and the skills that they've developed, as together we'll explore how the healthcare economy is transforming. Mark Miller is Executive Vice President Healthcare at Arnold Ventures. Most of us recognize Mark from his 15 years as Executive Director of MedPAC, a position where he significantly influenced federal health policy. Before his leadership of MedPAC, Mark held health-related positions at OMB, CBO, and CMS, which provided him with an unusually broad and deep understanding of health policy and how the federal government works. During his 15 years at MedPAC, Mark defined the position of Executive Director and substantially elevated the role of MedPAC and its bipartisan source of in-depth and insightful research and policy positions. Mark currently has a very interesting platform from which to influence health policy at Arnold Ventures. For those not familiar with Arnold Ventures, you'll find Mark's discussion of its purpose and agenda to be enlightening and refreshing. Mark holds a BA and MA from Old Dominion, and his Ph.D. in health policy is from the State University of New York. Well, good afternoon, Mark, and welcome.
Thanks a lot. I appreciate you having me on.
Well, we're pleased to have you at this microphone. We'd like to start with questions about the background of our guests. So what was life like growing up, Mark, for you?
I grew up military, so we moved all over the place. I lived all over the United States. I lived in Europe a couple of different times. I went to 3 different high schools, that type of thing. So a lot of movement.
Well, my dad was a minister and we moved all the time too. So they used to always say it was the PKs, the preacher's kid, and the army brats were the ones that were coming and going all the time. So I guess you went through that. Did you find there was any advantage to all that movement?
As a kid, and this is probably true of you too. I mean, whatever's normal is normal. And so you make what you make out of it. But I guess the thing that struck me at one point when I actually got to this area, and it was kids had been together since elementary school and then all the way at the end of their high school. And that just felt very claustrophobic to me. And so like I had seen a little bit of an advantage there, but who knows? It was very disruptive. And it was very hard on the family, that's for sure.
That is hard. Probably if you're like I am, you're good at meeting people, but you don't have a ton of really close personal friends that you didn't grow up with them. You became interested pretty early in public policy. All of your degrees, your bachelor's, master's, and Ph.D. are in public policy. What led you to the public policy interest, Mark?
Yeah, I went to undergraduate. I took government, but it was really a policy class from somebody named Richard Skinner. And he was a really good teacher, really engaging. And I think that was kind of what flipped the switch there.
And then where did the healthcare interest come from? Because it doesn't sound like you were really focused on healthcare earlier in your educational career.
I would probably have a hard time answering that exactly where that came from. So as I was going through, undergraduate into graduate, when I had policy papers that I had to write, I gravitated to health. I'm not exactly sure what the first attraction to it was, but I know when I got involved in it, I was really taken with how complicated it was, how much it defied normal economics. So I just, somewhere along the line, but I don't know that there was a specific event or anything.
Well, we're glad you did decide healthcare because you've had a terrific influence. Following your PhD, you probably had a choice of faculty or possibly coming to DC. What was the set of decisions you made there, Mark?
The program that I went to was focused a lot on methods and then sort of agnostic on the type of policy. And I went off to Albany and wrote my dissertation in Albany on healthcare. And so that was kind of my path. And then in graduate school, a lot of the people I went to school with, I would say even the majority, were headed off to teach. And there were parts of teaching I liked. I liked the actual classroom experience, but I still felt very strongly about going and doing, applied research and policy. That was something that I really wanted to do. And a, kind of ideal for me would be to go to the Urban Institute, which I ultimately ended up doing. But I do want to say this one thing now that you asked this, because something was said one night when we were all talking about our plans. And I was saying, I wanted to go to Washington and work on policy and have an impact, or whatever you say when you're a graduate student. And one of the other students said, well, I think, teaching students, generations of students over time is also a really effective way to have an impact. And I always thought that was a really important point. And one thing that I've tried to do when I, did get here, and particularly when I started managing people, was to always try and bring people along who work for me, like very much them, and, kind of bring them into their own careers.
We were chatting briefly before, and it's not too late for you to go back to academia, perhaps work at Arnold Ventures and in academia. Any university interested in healthcare would love to have you, Mark. So maybe that's your future.
Maybe.
In any event, you came to DC, worked at the Urban Institute. Then what got you into, I think, OMB? Was that your first governmental posting?
Yeah, so I had been at the Urban Institute for a number of years, and I was doing, the research and publishing. And I always tried to drive my research in the direction of being really policy relevant, as opposed to really, aimed at, I did publish in the journals and so forth, but not the real academic end of things. The health financing branch at OMB was looking for somebody to run that, and they reached out to me. And so I went to OMB and worked there for several years. But I was very interested in the move, both because it was very policy oriented and it was the first management experience that I had. And so that took me over there.
So OMB and then CBO, CMS, was that the sequence of appointments?
OMB, CMS, CBO, then MedPAC.
Before you got to MedPAC, any just fundamental lessons you learned from those three government postings that have carried on through MedPAC and now at Arnold Ventures?
There was a lot of similarities in the sense of trying to be the person in the room that, worked off of evidence, looked for a logical policy, looked for a compromise, looked for a way to get things done. But differences between them, OMB had, there were a lot of analytics, and there was a very kind of rigorous process of going to reach, say, a position on the part of the administration, and sort of looking across all the different agencies and pulling and information and pulling all that together to have an administration position. CMS was about implementation and, really a different role altogether, as opposed to just, making policy, coming to some kind of political agreement. It was actually operations, education, implementing the policy. And then CBO was much more analytic and sort of exercised an influence almost indirectly by saying, well, this is what the evidence is. This is how we think the world works. So this is how we would model or score this particular piece of legislation. And of course, that had a big impact on what direction the legislation went in. The amount of dedication and professionalism of the staff in all three of those places has stuck with me. People who worked and gave large parts of their life to get things done, working late, working weekends, working nights, that type of thing, and caring deeply about the mission of whatever of those three organizations. That was, something that was actually really inspiring.
Before you got to MedPAC, any just fundamental lessons you learned from those three government postings that have carried on through MedPAC and now at Arnold Ventures?
There was a lot of similarities in the sense of trying to be the person in the room that, worked off of evidence, looked for a logical policy, looked for a compromise, looked for a way to get things done. But differences between them, OMB had, there were a lot of analytics, and there was a very kind of rigorous process of going to reach, say, a position on the part of the administration, and sort of looking across all the different agencies and pulling and information and pulling all that together to have an administration position. CMS was about implementation and, really a different role altogether, as opposed to just, making policy, coming to some kind of political agreement. It was actually operations, education, implementing the policy. And then CBO was much more analytic and sort of exercised an influence almost indirectly by saying, well, this is what the evidence is. This is how we think the world works. So this is how we would model or score this particular piece of legislation. And of course, that had a big impact on what direction the legislation went in. The amount of dedication and professionalism of the staff in all three of those places has stuck with me. People who worked and gave large parts of their life to get things done, working late, working weekends, working nights, that type of thing, and caring deeply about the mission of whatever of those three organizations. That was, something that was actually really inspiring.
Probably not universally understood by those of us outside government, so that's good to know. What was the motivation then to go to MedPAC as executive director, Mark?
And so I had these jobs. I liked these other jobs. I want to be clear. But I always kind of had my eye on MedPAC because I felt like it had a particular set of ingredients that were really attractive to someone like me and could be highly effective. And ingredients in the following way. It had a congressional mandate. So it had stuff it had to do. And actually, it was a very pressurized environment. We had deadlines every month. And so either a public meeting, a report, or whatever the case may be. So it had to perform. The second thing is that although it's a creature of the Congress, it's independent, and its job is to give advice to the Congress. And it's also kind of quasi-governmental in the sense that you have a professional staff there, but then you have this set of commissioners who are not of the government, and some very explicitly, from the private sector. And it was small. It was 40-person agency in the end. So it was very manageable. You could get your arms around it. And so I always just thought, with the right approach, it could be a really effective, interesting place to work, and actually an effective place to work. So I kind of had my eye on it. And when the executive director position came open, I wanted it.
Well, you were there for 15 years plus, really defined the agency and set standards for your research and analysis that I think stood out among those in government. So congratulations for that. How did you develop priorities? It sounds like some of them were required, but there are probably others that you had some discretion to set. How did you define the priorities, Mark?
And let me hit how I did that, but I'll just say two other quick things before I segue into about what you just said. I think there was a real effort to kind of, remake the culture there and what the analytical principles and guidelines were going to be, so that the organization moved in a very systematic way based on evidence and in reaching policy conclusions, or at least policy recommendations for the commission. I think a second thing is to really establish a tight relationship between the agency and the committee staff. I wanted the committee staff that when they thought of the word Medicare, they impulsively reached for their phone and called us as their first call. The way priorities were made, and this does lead into your answer, because I wanted to both respond to the Congress and then also lead the Congress. But to get the Congress to listen, you had to know what they really cared about, which was part of the reason that you wanted to be very tight with the staff so that you could respond to what they needed. And then the commissioners would come in from the outside and say, why aren't we thinking about things like this? And so you could have this balance of being highly responsive to what the Congress wanted at that particular moment. But then you could incorporate ideas from the staff and the commissioners about where it should go. And people would listen to you because you were right there when they needed you. And when they picked up the phone, you were at the other end of the phone. It really was a process that came from the staff listening to the Hill staff, my staff listening to the Hill staff, and then the overlay of the commissioners. And of course, the chairs are very important there. And I worked with Glenn for years, Glenn Hackbarth, and then Jay Crossan the last years. And obviously, they have a lot of influence on the direction.
How are commissioners appointed?
So that process it's GAO that appoints the commissioners. This is all part of the enabling legislation for MedPAC. And there's a certain amount of definition that goes into the composition of the commissioners. Like they don't want, or the law doesn't want, a majority of the commissioners to be providers who directly benefit from Medicare, but then they want input from providers so that in designing policy, provider perspectives can be taken into account. Remember it, I probably knew it much better when I was there, but there is some delineation of the types of backgrounds they want people to have. And then GAO goes through a process of vetting people, and then they make the appointments.
Over the course of the 15 years, is it even possible to comment on what was the most influential policy issue that you worked on over that time?
Probably not single most, but I mean places where I felt like we had a big impact, on the drug legislation, and then how the drug legislation, Part D, evolved. Managed care policy, big impact, I think, on post-acute care, payment rates, and some of the redesign that is, even currently still going on, I think were big areas. We also spent a fair amount of time around the physician fee schedule and the SGR, if you remember those days. We had a lot of input on that. Those are some things that come to mind, and there's specific issues which may be just too detailed for this that I could delineate, but those were areas where I remember specific issues being played out and having some role in the direction it went in.
Any policy area that you wish you'd been able to work on that you weren't able to work on for some reason? First
of all, I'll say every one of those policy areas has incomplete issues. So there's that, what is it? There's no new issues, just new analysts. So those still have issues that would be good to complete. what was also complicated at MedPAC is that, there's the whole dynamic of what policy and what kinds of consensus you could get on the commission, and then of course within the Congress, just to move Medicare. But then there were issues outside of Medicare that had a big impact on what went on inside Medicare, that as a matter of your congressional mandate, you couldn't speak to. So, hospital consolidation in the private sector had impacts on Medicare, but it was out of our reach. What the FDA did about, the issuing of patents and FDA issuing market exclusivities all would affect the drug markets, but very much beyond our reach. So there were things like that you couldn't get to because of the mandate of the commission.
So after your 15 plus years, why did you decide to leave?
There's probably a few things. Part of the answer to that is in the question. It was 15 years. I want to be very clear. I really enjoyed it. And the thing that I probably liked the most about it, and I will answer your question, was the crew that I worked with at MedPAC. And I mean, I'm just going to reinforce this again. I mean, these are people who, almost all of them could have gone somewhere else and made more money, and they didn't. They cared deeply about the mission. They cared about getting the right answer. They too, like some of the other people I'd worked with previously, gave up, large parts of their life to, execute the job. So it was a very difficult decision because of the organization itself, but also the organization's mission and that type of thing. But a very personal decision because of the people there that I had worked with for so long and had very tight relationships with them. But I think some of it was 15 years. Some of it was I felt like there had been a lot of kind of building culture and methods, pathways, whatever you want to call it. And, the institution was working. And I think it's always important as someone, who leads, that it's absolutely important that the apparatus that you set up can run without you, right? That should be an objective as a leader. And it was definitely at that point, had been at that point. And then I had a few conversations with the Arnolds, and it felt like there were parts of the agenda that I just named to you that I could get to more broadly. And after a few conversations, I think the Arnolds and Kelly, who's the president, and myself got to a place where we sort of had a shared view on what an agenda could be. I would say that. And then the second thing I would say is that they were also pretty courageous. Like, they understood that some of the issues they were going to take on, not just with me, but elsewhere, but definitely with me, they would get flack for it. And they were up for that. And I think that that probably had something to do with, they wanted me to build something here. And I kind of liked that idea too.
Did you look at it as you could achieve some goals at Arnold Ventures you just couldn't achieve at MedPAC because of the charter of MedPAC? Was that part of the thinking?
And, you've been around Washington enough to know that it's so hard to really move things. So I don't want to overstate it. Arnold Ventures probably gives me some more freedom to speak more directly. At MedPAC, you could advise the Congress, but you couldn't admonish the Congress. You can do that now. Also, there's sets of tools that you can be more aggressive in terms of the communication and pushing a message. Whereas again, At MedPAC, you advise, and then you let the Congress take its course. And of course, the people who didn't want our policies to be implemented were actively, lobbying and pushing their messages on the Hill. And that's not a role that MedPAC really could play. And so in that sense, there's sets of tools here that I didn't have there. And then there were certain parts of the agenda, a couple of them that I named, that, I can still deal with Medicare stuff here, but I can also deal with the broader environment.
You were there for virtually all of the George Bush administration, all of Barack Obama administration. This isn't meant to be a political question, but more of a how did the administrations operate type of question. But could you characterize the difference between the two?
Let me say this. First, one thing that was interesting about both, the period. Now remember, I'm in a legislative, position at MedPAC. I'm dealing with the Congress, and there would be changes in kind of Democrats, Republicans, movements there. But behind it, there would be the administrations. And so, your question stands. One thing that was really interesting to me, and this I don't think was accidental, because it was certainly part of my agenda, was to always have a set of ideas that I could use, no matter what direction a piece of legislation was going. And so one thing that I found is a good portion of the ideas that we put on the table, both administrations picked up and put in budgets, or both administrations would pick up as part of some legislative effort. And there was a lot of overlap between those two. And even though they would carry on and snipe at each other about their various positions, there were whole sets of policies that came out of MedPAC that were always in both packages. But then where they would diverge would be the places where exactly you would expect, if the Republicans dominated or there was a Republican administration, it tended to always be seeking things that drove more in a market direction. And on the Democrats' side, they would be more open to something that would be more regulatory. And of course, I always wanted them both to consider both because both are needed. Was always trying to bring people together on that front. But in a funny way, when they put their budgets or they tried to run their legislation through Congress, our part of it was often the same.
Well, I think that's a credit to you. And you were always known when you were in that job as somebody who did seek balance and didn't overweight one way or another. So credit to you for sure. Well, let's go back to Arnold Ventures. What's the agenda now? Can you describe that for us?
So what we've worked out, or myself and the board worked out, is the first thing I would kind of put into your head is that this is my portfolio now, and there's many other portfolios around the organization. Well, mine is about cost containment, reducing costs for a taxpayer, employer, the patient, the people who pay premiums, support public programs, pay out of pocket. We have portfolios that are aimed at things that are prices and things that are aimed at utilization. So we have a huge portfolio on drugs, which is aimed mostly at the prices of drugs. And we have competition-based policies, research and policies that are aimed at kind of the middleman, the PBM, those types of transactions, and then policies that are very much aimed at, trying to extract a better price. We have a portfolio built around the prices of what mostly hospital, but increasingly physician services in the commercial sector. So the drug stuff is both public and commercial. Prices in the commercial sector, and you know the story here, tremendous amount of consolidation. Consolidation leads to higher prices. What do you do about this? And by the way, one little spin-off issue on that was the surprise billing, which we were deeply involved with both on research and policy in the most recent legislation that came out. Another portfolio is about low value care. So there's a lot of research that suggests not all the care is either helpful to a patient, and in some instance actually is causes damage or injury to the patient. And so how do you define that? How do you put it in front of the provider, probably first, patient too, but probably the provider first, and then create a financial incentive to avoid it? And then finally, complex care. So think of the 5% of the population that defines 35% of your spending. How would you manage care in that particular environment so you get a better spend for the dollar? That's kind of the broad stroke, sort of 4 parts of the portfolio. We fund research. We develop policy either with the researchers or ourselves. We provide a tremendous amount of technical assistance. And then with other people in the organization, we engage in advocacy and communications.
Well, you mentioned the Arnolds are courageous people with that agenda, particularly with drug pricing. I would say they need to be to make some progress.
This is the thing about them. They have been attacked directly by the drug industry, and they have shown they have not flinched, and they have just stayed right on course. And there's a lot of philanthropies around that wouldn't do that, take these issues on, because there's a lot of, part of the reason that I wanted to position the Arnolds in this particular way, and they were thinking along these lines too, is there are other people out there who are very involved in coverage and quality and other sets of issues, all fine issues to be pursuing. But a lot of people don't want to talk about the cost containment. It starts to get uncomfortable because somebody's got to get less, and people just don't want to get into that. And they were willing to go in that direction.
Mm-hmm. Can we dig into complex care for a moment? My personal opinion is we don't do enough in that space, just generally speaking. So I think it's terrific that you have that as one of your pillars. What kind of programming are you undertaking in that area, Mark?
So mainly our agenda to date has been around the 12 million dual eligibles, Medicare and Medicaid eligible. Gone in that particular direction because it's a lot of spend. It's I think hopefully his fact is right, but it's got to be $300 billion or north of that annually. Medicare and Medicaid, you have 2 actors who care about it, a federal government and a state government. It's expensive. You've got an incredibly vulnerable population. And I think you're right. And part of the reason that it's so difficult to move and make progress is what we know and what we understand in that as a matter of what works for the particular kinds of populations in question is directional, but not certain at all. It's complex care, but it's a fairly complicated topic to get into.
It is that. There's a lot of human factors that come into play too. It's not the most attractive group to be studying, right?
People don't pay attention to poor people, pay attention to poor, sick people. So yeah, if that's what you mean, the answer is yes.
Yeah, I think that's true. One question, just from a kind of an overall question, you're at Arnold Ventures, you work on something like surprise billing. I think you were pretty influential in that space. But generally speaking, how do you actually measure your accomplishments in areas like this?
I think there's a few things. I'll try and answer that question, except just for the record and for my bosses, we've been wildly successful. Okay, we'll just leave it. But let's be honest. These directions that we're trying to go in are extremely hard, and there is a well-motivated, well-funded resistance to it. Whether you're talking about the pharma, pharma's resistance or hospitals or whatever the case may be. And so I think there's a few things, and I think they think about things like this, but I don't want to speak too much for them. But one of them, they come very much from a direction of knowledge and evidence accumulation. And so if you build as part of your portfolio, a set of researchers and a set of evidence that, can then in turn drive policy and then ideally, real change, one accomplishment is just to have a set of a momentum and a set of actors and a set of research that's coming out. And they very much come from a place of evidence matters. And so I think they see that as part of the accomplishment. But the other part of the accomplishment is, but what changed? And that is, of course, the much harder one to extract. And it can be something like surprise billing, where it changed. We pushed very hard on it. But to be honest with you, the final legislation is not the legislation we would have written. There's been some movement in the recent reconciliation bill where very small kind of drug ideas, one-off drug ideas, are getting pulled into it. You might look at that as accomplishments. But what they really are looking for, and what I'm trying to push for, is I would like to see, like in a second reconciliation bill as part of that more major drug legislation get pulled along as part of that. And then just one other thing I'll mention. We also work at the state level, and you can see progress at the state level. Recently, Medicare passed the Drug Commission and then funded it, overriding a governor's veto to do it. And there are examples like that, both on the drugs and on the prices side, commercial prices side, peppered throughout the states, where you can clearly point to pieces of legislation trying to move their way through the state legislature.
Do you ever get discouraged? Let me just, the preface is healthcare now is almost 20% of the gross domestic product of the country. It's huge. There's a lot of money here. There's entrenched interests. There's people that have spent their careers pursuing a particular area they don't want to change. And you and all the colleagues you've worked with through the years are trying to reform things, basically. Do you get discouraged that you just have to take little bites here and there as opposed to some broad sweeping change?
This could be the shortest answer yet. So the answer is yes, and you do just see this, this overwhelming, mountain or wall that, moving through will be incredibly difficult. Now, I don't know how to say this, and I'm trying in my head to figure out how to say it, politely or professionally or something like that. I don't know how much idealism I had to begin with, but if I did, I don't know that there's much of it left. And I just think it's the unfairness of the situation that motivates me at this point. There's just so much of it that isn't right and denies people access to their drugs, undercuts their wages because they, have to pay premiums. They can't meet their deductibles, whatever the case may be. And if there was a truly innovative, high quality and a reason to pay, top dollar, I think there's an argument for that. But so much of the money that's moving through it isn't being driven by that. And it's just money coming out of households one way or the other. And so it's almost like, yeah, I get discouraged, but it's almost that just keeps me, an unwillingness to give it up, I guess.
That makes good sense. The coronavirus pandemic pinpointed a number of gaps and inequities and unfairness as well. Any thoughts about that and is there any kind of learnings about that that could enter into your agenda at Arnold Ventures going forward?
I hope this doesn't sound too pat, but I mean, it exposed so many of the things that we're pursuing. I mean, the fact that you could be charged $300 or $3,000 for a test, the fact that it would be covered or it wouldn't be covered, the fact that the disparities in the impact of the virus, by race and nursing homes, talking about the complex care, the affordability of all of it, comes into question. So we've been carrying major debt in this country for years. And, a rant that I've been on for many years is that we can't carry this debt because of its drag on the economy, but also because what if a real emergency happens and we need to ante up? We have a real emergency and we need to ante up, but it would have been better to start that, in a much more fiscally secure position than at almost 100, a debt equal to 100% of GDP, and then just blow it out from there. So, if we had had a grip on our health spending problem, we might have had more resources that we could throw at it without having to go into debt. And then I'm just going to say this, and this is not my particular turf, but I mean, clearly we have not prepared in this country for a public health emergency. We don't understand it. We don't have the apparatus. That's not an area that I've worked, but that seems very clear.
That's very clear. Mark, we need to run you for office. What district do you want to run in?
Yeah, you don't want me in office.
I think that actually would be pretty good. But yeah, public health's been a problem for forever, really. I mean, we went through this 100 years ago with the 1918 flu, and a lot of what we're doing today is pretty much what they did back then, right? So hopefully out of this will come a bit more financing and support for public health. The apparatus, the infrastructure definitely needs to tick up. On the evidence-based side, the 1% steps for healthcare reform, I know Arnold Ventures has been supportive of that initiative. I think it's relatively new. Can you just describe briefly that initiative for us, Mark?
Zach Cooper from Yale came to us with this particular idea, and it rang a couple bells for me that I'll get back to. But what his idea was, and I'm sure I'm not going to do it justice, so I'll apologize to him in advance. But the notion that he believes that economists have something to say and to help where health spending is concerned, that there could be smaller bites that could be broken down and more definitively defined the savings that could be gotten and how to communicate with the policymakers, I think was his thinking. For myself, the attractiveness of it is going back to MedPAC. I always had a list of ideas, and they could be more market oriented or more regulatory, but and they could be in different areas, managed care, post-acute care, whatever the case may be. I always had a list. And, if somebody was like, we need offsets in order to do this thing we care about, it's like, well, you've come to the right place. Let me give you a list. And I sort of saw what Zach doing is kind of a version of that type of thinking, where he would develop this with his, fellow economists and then package it in a way that is more consumable for the, the policy types. Quite frankly, Hill staff is the way I would think about it. And I've certainly tried to help him connect, more directly with them. So what I see there, and I think an important thing, even beyond the specific ideas, is the general attention that it draws to the need and the opportunity for savings in the health environment.
You've got a great longitudinal view of healthcare. The question would be, what do you think the major change of the last decade was in healthcare in a positive sense? And where do you think we're going to be in 2030? So just what was the last 10? What will this decade, where will we end up being?
Because, I generally focused on all the problems. This is a very difficult question for me. I think, and I think my adversaries in the drug world will be surprised by this. I do think there has been true innovation in the drug environment. And I do think that there has been, steps there that specific scientists, specific manufacturers, should be proud of. I would just quickly restate that what I've said elsewhere. There's a lot of work that comes out, basic work that comes out of the NIH, but manufacturers do turn that into real products. And I do think that there has been progress there. I think the organization of delivery systems and payment systems coming together in order to try and have a better focus on efficiency efficiency, cost on the one hand, quality on the other, which efficiency is supposed to be those two things, and a real effort to try and bring those together and focus on it. I don't know that it has been entirely successful, but the notion that that has become something that's more of the coin of the realm, I guess, I think is probably a positive thing. I think at great cost and in great pain, the recognition of the inequities that run through the system, I think the recognition and not the resolution, just to be clear, the recognition has been a good development for people to understand that inequities run through the issue, throughout the system. And I think the recognition of affordability as an issue for families is important. But those all are open-ended problems that are not solved.
You could think about it as, where are we going to be in 2030, or what will the major trends be over the course of this decade?
I don't know that I can answer your question precisely, but what I will say are these types of things. I do think the affordability from the perspective of the taxpayer, an employer, a family, will be, the defining issue. And the question will be how we ultimately come to that, whether it's the sustainability of Medicare and, even recently outrunning the HI trust fund and the fact that Part B just draws from general revenue and how sustainable that is. The employers, if they ever would, wake up and realize that this is something that they have to address, that it's eating their budgets. And when you have, 40% of American families unable to get together $400 in an emergency, we've got to do something, because having, the way the health benefit is moving, because of the costs that I'm referring to, they become much more, they're pushing much more onto the consumer through deductibles and copayments that they don't have. And so that reckoning feels like it has to come to a head. I think the other thing that's got to be, in the next 10 years, and I just hope we don't have, our usual amnesia in this country, is preparing for a public health emergency, which we've clearly just ignored for decades and decades. So those are not like what will happen. Those are probably half wishes more than anything else.
Yeah, well, I think that's probably the best you can do in that space. I agree, affordability will be the issue of the decade. I don't think there's any way out of that. It looks to me, Mark, like there's a shifting of risk from the employers and the payers to the consumers and the providers. Do you see that? Would you agree with that formulation or not?
Oh, no, I do agree with that. And I think the way the providers have responded to it is to consolidate and extract, in some instances where they can, higher prices, or to try and design payment systems that help them kind of protect their particular revenue stream. I think you've seen a lot of that in the alternative payment model process, where particular groups of providers will come together and say, well, let's build a payment model around what I do. And sometimes I think it is well motivated and intended to result in a better product. But I also think there are attempts here where it's just to build a moat around a particular set of revenue. So yes, I do think that things have become less affordable for the employers. And so there has been this redesigning of health benefits to push much more on to the consumer to the extent that they can do it. So I would agree with that.
You made reference before, but the financing side coming together with the delivery side, some have called that the new middle or the new financing middle. And I agree with your point that we've seen some movement in that direction, but it's going to have to be a lot more to really have a major effect. And the question is, do you think that the private sector can move down that path, or is there going to have to be some legislation to push them in that direction, or at least to offer an incentive to go in that direction?
Like an alternative payment model, an ACO, or managed care organization, or different permutations of a managed care organization. One of the reasons that I think their performance more recent years, has not been that large of an impact is because our utilization has not been the same problem that it's been. I'm an old guy at this point, and I can remember decades where utilizations was growing extremely rapid. And I find this very frustrating when I talk to employers, or I talk to insurers to some extent too, where you'll talk about healthcare spending and they'll immediately go to, we need to manage utilization. And I want to be clear, you need to set these models up because we don't really understand kind of the waxing and waning of utilization. And if it starts to accelerate again in the future, we should be positioned to do something about it or to curb it. However, particularly in the commercial sector, it's prices that are driving the spending. I think there are several arguments that come into play. They don't understand the environment well. They feel like they don't have enough power as a single purchaser to do anything about it. There's probably some compromising positions in the sense that you're in a community and that you're parts of boards and so forth, and there is an employer on the board with the hospital and that type of thing. So you have sort of some of those complications. And I think that is going to drive, ultimately, if nothing is done, it's going to drive government intervention, because if people don't take action, and I think the employers, many would legitimately argue they don't have the market power to take that action. It's going to drive government intervention. And that can go in the direction of curbing anti-competitive contracting behaviors, like in the Sutter case. But it also could go to just start to say, look, when you start charging at this or extracting payment rates at this level, you've begun to abuse the system, because you've got too much market power. And so I kind of think that when you say, do they need, will it take some government intervention? I think they need help, because I think their problem in some ways isn't solvable by them because they don't have the reach to push back on a highly consolidated provider sector. And I just want to be clear because the providers will get very angry about that. I stand by what I said. You can also find markets where insurers are consolidated, but it is not the same problem, in my opinion, as the provider consolidation.
Well, the incentive positioning is certainly a key issue, and this has been a great interview, Mark. I wish we had more time, and hopefully you'll join me again. I'd like to ask one final question, if I could, and that is, you're a long way from wrapping up your career, but when you do, what would you like your legacy to be?
I'll say this, and in a funny way, it goes back to the head of the conversation. I mean, I hope there's some knowledge base that I've left out there. I hope there's some policy impact. But what I really hope is that there's a set of people that I worked with over the set of years that feel like they had some kind of positive experience, some kind of learning experience with me. And then they, continue to carry that forward. Almost like this question of should you be a teacher or should you be a policy? So that's what I would say to that surprise question that you just.
Well, I love the answer, and you don't appear to be surprised, so all good. But thank you, Mark. This has just been terrific. It's been a real joy for me to conduct this interview, so thanks for being with us.
I really appreciate it.